Before we dive in, a quick note. We are brand new to this and we're still figuring out our equipment. So the audio quality on these first few episodes may not be perfect. We appreciate your patience while we work out the kinks, and we promise we will get better. Hey everyone, welcome back to the dark side. Quick note before we get started. If you're watching this on YouTube, this is an audio only podcast, so you're going to be looking at our cover art for the duration of the episode. We record in audio format and distribute to both our podcast platforms and YouTube so that everyone can find us wherever they like to listen. So if you're on YouTube, welcome, grab some headphones, get comfortable, and go for a walk. And know that the lack of video is completely intentional. And I said, get comfortable and go for a walk. So I don't really know if that goes together. It doesn't for me. So get comfortable or go for a walk. I'm your host, Heather Skousen. Joining me is also my co-host, Dena Diamond. If you want to understand our background in healthcare and criminal justice, feel free to read through the podcasts on the description or listen to some previous episodes because we do go into our background. Welcome, Dena.
Hi, thank you. I do want to say that this one has been a long time coming. This is a topic that I have seen play out in real time. And I think that a lot of people will recognize it as we discuss this today, but they have never had a name for it.
Yeah, I agree. All right. And Holly, our guest, is here with us again. Holly comes to these topics completely fresh. She hasn't been briefed on the case. She doesn't know what's coming, and that is entirely by design. So, Holly, welcome.
Thanks. I'm reading your script here, and it tells me I'm supposed to respond. You didn't prep me for that.
Well, okay. Well, it is supposed to be that you get authentic responses, so I didn't want to tell you what to say for welcome.
And really, when I say I'm looking at the script, I'm looking at it for the first time right now.
Yes, thank you.
Dena just pointed out, be prepared with your response.
I am glad that you at least admitted that you haven't seen the script. So, okay. Well, today we're pulling back the curtain on something that happens every single day across the American healthcare system, something that costs taxpayers billions of dollars a year, distorts medical decision making, and puts patients in the procedures and on medications they may not need. We're talking about the kickback machine. You guys ready?
Ready.
Let's go.
Let's get into it. All right. Okay, so let me get in here. Let's start with numbers.
Okay, wait. I want to stop for just a minute.
Do you want me to stop recording or just stop?
No, because we've got these little dogs around here, and you didn't address the dogs.
Oh,
That is
yeah.
true. There's been previous episodes where I have addressed that we have dogs, and there's other episodes where I have not addressed that we have dogs.
Yes, they're
We
cute.
do have two adorable dogs in this household, and they like to join in sometimes by sharing their voice, or you just might hear them eating and drinking because they're right next to us while we're doing this.
Well, and they seem really needy tonight because they keep coming up and licking my hands, my legs. So sorry if you hear me.
Yeah. Holly had to take care of them recently, and so they are very fond of her lately. So they're just missing you and sharing their love, all
They
of
can
their
keep some of their
kisses.
love to themselves.
Can
They
you
are
tell maybe
sweeties.
Holly's not a dog person? All right. Okay, let's start with the numbers. In fiscal year 2023 alone, the Department of Justice recovered more than $2.7 billion in settlements and judgments under the False Claims Act. And the majority of that money came from the healthcare industry. That is not one bad actor. That is not an anomaly. That is recurring annual systemic pattern of fraud and corruption that the government settles, collects money from, and then watches happen again the following year. Like, it just keeps happening. You looked at me like,
Groundhog
okay,
Day.
yeah. A significant portion of those settlements year after year involve violations of the Anti-Kickback Statute. And that is what we're talking about today. Not one company, not one doctor, a machine, an ecosystem of financial relationships between pharmaceutical companies, medical device manufacturers, and the physicians who prescribe their products and use their devices.
Do you go into what the anti-kickback?
Yeah.
Okay.
Yep, I will. So in some cases, they explicitly intended to influence medical decision-making in exchange for money.
So we need to be precise about what we mean when we say kickback, because that could conjure up a lot of specific images.
Well, I think that's why probably Holly asked the,
That's why I
asked the
That's why she asked.
question.
An envelope of cash? A handshake in the parking lot? That's not what we're talking about.
We're thinking about like the mob. Is that what we're thinking about?
No, that's not what we're talking about. At least not primarily. The modern healthcare kickback is sophisticated. It is laundered through consulting agreements, speaking fees, research grants, meals, conference sponsorships, and investment opportunities. It's dressed up in the language of education and professional development. And it's extraordinarily effective.
Yeah, totally. The federal law that governs this is the Anti-Kickback Statute. You asked me if I was going to tell you what this is. Okay, so there's a whole code to it, 42 USC section 1320A 7BB. Like we will link the references in the description for you guys to find this if you want to look it up. It prohibits offering, paying, soliciting, or receiving anything of value to induce or reward referrals of items or services covered by federal healthcare programs. It has been on the books since 1972.
Wow.
And that's a long time.
Right. Yeah. So I have a question on that because I'm relating it to something that am familiar with. As a state employee, I couldn't accept a gift over a $50 price tag because it was perceived as a bribe in a way. And is that kind of similar to what we're talking about here?
Same concept.
Okay.
Yep. Okay. And it does have teeth. Violations are felonies. Okay. Carrying up to 10 years in prison per violation. And yet the conduct it prohibits is so widespread, so normalized, and so cleverly structured around its own exceptions that the law has functioned less as a prohibition and more as a speed limit. Oh, there we go. You tell that he is just disgusted by it.
Just disgusted. Bandit. Wow. I know.
And honestly, mostly the industry treats it as just an advisory.
And alongside with the anti-kickback statute, we have the Stark Law, formerly the Physician Self-Referral Law, 42 USC Section 135 NN, where the anti-kickback statute requires proof of intent. You have to show someone meant to induce referrals. The Stark Law is a strict liability statute. It prohibits physicians from referring Medicare patients to entities in which they are their immediate family members have a financial interest, period.
So like if they themselves have a financial interest or their family members have a financial interest, right? So it could be like my brother owns.
So yes, you cannot just refer to them because then they have the financial interest. So, and yet the Stark Law has more exceptions than almost any other statute in federal healthcare law. There are exceptions for in-office ancillary services, for group practice arrangements, for fair market value compensation. Entire law firms exist solely to help healthcare entities structure their arrangements to fit within Stark exceptions.
So you're meaning that these law firms exist to help the medical practice get around the Stark Law?
Where they're supposed to be showing them, like, not what to do.
Right.
It's, well, you can't do this, but
you
can do this. Yeah. So just what you said.
Interesting.
So we have two powerful federal laws, the Anti-Kickback Statute and the Stark Law, both aimed at the same underlying problem, which is financial relationships that corrupt medical decision-making. And both have been systematically outmaneuvered by an industry with billions of dollars and armies of lawyers. That is the setup. So now let's talk about exactly how it works. Okay. The first one is the speaker program. It's a paid dinner with a prescription pad. Okay.
Oh.
I know. So we're gonna kind of explain what that is. Let's start with that, because they are the most visible and most documented, and arguably the most brazen component of the kickback machine. Here is how a speaker program works in practice. A pharmaceutical company identifies physicians who prescribe or who could prescribe their drug. They invite those physicians to become paid speakers to educate their peers about the drug's clinical profile. The physician receives a fee, anywhere from a few hundred to several $1,000s per event, plus travel, meals, and in some cases, accommodations. The educational event often takes place at a restaurant. The audience is frequently other physicians who are also speakers, so for the same company. So you're all
Yeah.
there, you're
Like
talking to somebody else who has the same arrangement as you to talk about
somebody
something.
else's product.
Yeah,
Right?
exactly.
The pharmaceutical, like, this is not the pharmaceutical talking at
No,
a dinner.
this is
It's the
this is the
doctor
physician. Yeah,
talking
exactly.
about the pharmaceutical.
So obviously it's going to be something where maybe that doctor has already tried the medication for some of his patients, and so he's now talking to his peers to talk about why he's a big fan of this medication.
But all of the peers are there doing the
the exact same thing.
So
it's really a discussion
yeah,
more than being a speaker.
And a nice vacation.
Because
And
the
a nice
restaurant
vacation.
may not be just down the
Mhm.
street. The restaurant
Right.
might be in the
Yeah.
Bahamas.
Yeah.
Yeah, I mean,
Greece.
right, or
yeah.
Hawaii,
Potentially.
you know?
Yeah.
I mean, exactly. And the content by multiple government investigations is often standardized slide deck that any medical sales representative could present. So
that's just
it's just
read
pre-planned.
this slide,
Yeah.
and then talk about it.
Exactly. The research on the relationship between speaker program payments and prescribing behaviors is damning. In 2016, study published by JAMA, Internal Medicine analyzed Medicare Part D prescribing data linked to the Open Payments database, which we'll get into later on. But they found that physicians who received even a single mill from a pharmaceutical company were measurably more likely to prescribe that company's brand name drug over a therapeutic equivalent. I mean, we're talking about a single mill.
Well, did they have any evidence about where the meal came from?
Right?
Because I think there's.
Are you thinking like that maybe if the mill was fast food, it didn't really
maybe didn't
play into making the decision?
Because I would respond for one thing over another thing, definitely.
I mean, that's true. I might too, right? The effect size increased with the number of mills received. So, I mean, Holly, maybe if you got a lot of fast
Well,
food
yeah,
mills.
a lot of good ones.
Yeah, exactly. Versus one good one.
Yeah.
This is not a coincidence. This is a dose response relationship between payments and prescribing.
Well, they had to show that the more you use something, the better outcome. So, like, that's the same with the pharmaceutical.
Isn't it like
Right.
You can't just take one dose of a medication and make it work. You have to.
you have to get it in your system. So
Yeah.
it's like the Pavlov response,
Pavlov's
like
response
yeah,
to the
like the
dog.
dog,
Yeah.
right? Isn't
Yeah.
that what I was thinking
Saliva.
of?
Yeah.
Yeah. And the companies know the companies know this. So what you're just talking about, Holly, is that this is already part of their business strategy. They track it. Their sales force analyzes prescribing data, which is commercially available, and measures the return on their speaker program investment by watching whether a physician's prescribing patterns shift after they begin receiving payments. If the numbers move in the right direction, the relationship continues. If they don't, the speaking engagement dries up.
Well, that's just
Interesting.
like medicine, because if it works, you continue to use it. So the pharmaceutical is just a company is just mimicking their business model mimicking their.
You literally could go work at the pharmaceutical company and tell them why they're doing this based off of
Because their business model is just mimicking what
you're trying to sell.
What's working, what's not. The most extreme version of this, and the one that resulted in a landmark federal prosecution, was Inzice Therapeutics, the maker of Subsize, which was a fentanyl-based sublingual spray, and it was approved for breakthrough cancer pain. Subsize ran a speaker program that the DOJ characterized as a straightforward bribery scheme. The physicians were paid speaker fees that correlated directly with their Subsize prescribing volume. Some speakers gave the same talk to the same audience multiple times.
Yeah, I mean, like,
Mhm.
I know, I guess. I mean, gosh.
Yeah. In 19, I'm going back. It was 1919, the beginning of time. In 2019, the company's founder, John Kapoor, was convicted of racketeering conspiracy, and he was sentenced up to 5.5 years in federal prison. This is one of the few cases in which a pharmaceutical executive faced personal criminal accountability.
So that was.
Do you think
my
they're?
question.
Yeah.
Does this usually if it does get brought to the court system, is it an individual that is charged, or is it usually the company?
We kind of
Well,
talk
maybe
about it a
it's
little bit later
Yeah,
in
or
here. So
so that's why he was held responsible.
he was held responsible. We'll find out a little bit later what really happens. That's why this one was kind of a landmark, because it happens. I just don't think as frequently, because if it did,
Yeah.
then,
You'd be hearing about it a lot more, right, in the news and stuff like that.
right. And the fact that they could track it is itself part of the problem. The prescribing data has been commercially available for purchase for decades, which means pharmaceutical companies have had real-time feedback loop on the effectiveness of their influence operations. So kind of like we were talking about, that data is available and has been restricted, but the practice of tracking physician-level prescribing behavior, my goodness, tonight, shaped the entire architecture of how these relationships were built.
Okay, we've announced before that we do this after we already are doing our full-time job, so
I just
we're
need to slow
tired.
down, take a deep breath.
Dina's just so excited about the subject that she's just like
calm down.
stumbling over her words. Okay. The consulting agreement is the speaker's program's most sophisticated cousin. A pharmaceutical or device company identifies a high prescribing physician and offers them a consulting contract to advise on clinical trial design, to provide feedback on marketing materials, to serve on an advisory board. The compensation is described as fair market value for the physician's time and expertise. And sometimes it honestly is, right? The problem is that the line between legitimate consultation and purchased loyalty is almost impossible to draw from the outside. And the industry has exploited that relentlessly.
I was just going to say, I do want firsthand experience reporting, like to say how it's
right
benefited patients and things like that. So I can see where that line does get blurry.
Yeah, for sure. Right.
It's when they start getting paid
for that expertise or for that feedback. Yeah. The OIG has published.
What's the OIG?
Oh gosh, Holly, you were gonna totally ask that.
No.
It's a compliance program. Oh my goodness.
Sorry.
Oh my goodness. Okay, I'm trying to think. I think it is the Office of the Inspector General. Is that kind of ringing a bell? I'm thinking that's what it stands for. I mean, we could hurry and look it up, but I think that's what it stands for.
You keep going. I'll look it up.
Okay. The OIG has published guidance.
Yes, that's what it is.
Is that what it is? Okay, perfect. Okay.
Yay.
Oh my goodness, you asked me these questions. I usually have that information on me, but I just didn't have it this time, so I apologize. It has published guidances on what distinguishes a legitimate consulting arrangement from a kickback dressed as one. So a legitimate arrangement has a defined need for the services. Services are actually rendered, compensation reflects fair market value, and the arrangement is not tied to the volume or value of a referral. The problem is that fair market value for a physician's time is itself it's manipulable. It's
manipulating.
It's malleable, and you can manipulate it, right?
Mm-hmm.
Exactly. Companies commission fair market value analysis from consulting firms that, unsurprisingly, tend to produce valuations that justify the payments that the company wants to make. So you basically say, I want to make this much money, or I want to pay this much to get the physician to do what I want. So I'm going to say that dollar amount is fair market value.
It's a loophole.
Okay, it is a loophole. Okay. I have another acronym on here that I know I'm going to need to pull for you. So
I was looking at it.
Were you looking it up for me?
Yeah, I'm finding that it's a nonprofit.
Okay. The correlation between consulting incomes and prescribing volume has been documented repeatedly. In 2021, the study in medicine, the PLOS, so that's the non-for-profit in medicine, found that physicians who received payments from opioid manufacturers were significantly more likely to prescribe opioids at a higher rate. Right. And I mean, we're in a situation right now where we're in an opioid epidemic where we're trying to avoid prescribing opioids.
I think that's some of these things is what really got it going.
got it going,
Mhm.
right? Exactly. I think that there's Holly, you are our entertainment guru, and I think there's actually
You
a
thought of
show.
something?
There's a recent show about the opioid epidemic.
Oh no, I'm drawing a
Oh my
blank.
goodness. I'm trying to think of what it is either, but
Oh.
I'm trying to think of like who even was the actress that
I'll figure
was
it
in
out while
it.
you're
Yeah.
Oh.
But it's a whole
Probably wasn't
it
fun
might have been
one.
on
If it was
Netflix or on Hulu.
if it was new, I
People who
probably
are
didn't know
listening
it.
might know what we're talking about because they might have watched it. But yeah, look it up. Look up like Hulu or Netflix show about the opioid epidemic. And it's based on like it starts with pharmaceutical
Right, it
companies.
does. It
Painkiller?
does.
I think it is.
Probably
It's
Painkiller.
Netflix.
Netflix.
And yeah,
Okay.
it will show in there that they were selling it as
They were
non-addictive.
non-addictive. Exactly.
Or there's another film called Pain Hustlers.
I think
Mm.
it's Painkillers though that's on Netflix that I'm thinking of. The relationship persisted even after controlling for specialty, practice setting, and patient population. So that is the consulting aspect. Now, the next one is the device rep. This one is where
Mhm.
Dena and I have been
Yes.
exposed to this quite heavily in our background with interventional radiology. Okay. So let's talk about it. The medical device side, because it has its own specific dynamics that are worth understanding separately. Medical device representatives, the people who sell surgical implants, cardiac devices, orthopedic hardware, vascular equipment, have historically had extraordinary access to physicians, not just sales calls in the office. They are in the operating room.
Yes,
They are
they are.
present during the procedure. They are advising on technique, building a personal relationship with the surgeons, and by design are deeply intertwined with the clinical decision making. So, this is somebody who works for the medical device company who's in the room with your provider, with
While
your
I'm having a
physician,
procedure done.
and they're telling them, like, this is why you want to use this device because it can do this and this and this, right?
So instead of the physician focusing on my health in the moment, they're thinking about this other individual
how
who
much do
keeps
I like
interjecting.
how much do I like this
And saying this is
device?
why you need
Need
this.
this.
I will tell you, like, the experience that Dena and I would have with this is more often than not, our physicians didn't like those representatives being in the room.
But sometimes
But
there's some
sometimes,
things where it's like, well, we have to bring
yeah, because
this.
the doctors
You
don't
need to be
do
there
the
enough.
procedures enough to
Mhm.
feel comfortable without the representative being there.
Yeah, so the device industry approach to physician relationships has produced some of the largest False Claim Act settlements in history. And I'm sure there's people
Some
who've
of
had
these
to
names,
hear,
yeah.
Stryker, Zimmer, DePoy, Biomet, and Smith and Nephew. These are 5 of the largest orthopedic device manufacturers. They collectively paid over $300 million in 2007 to settle DOJ allegations that
Just
they had.
300
Yeah.
million
And that's just to
in
settle.
settlements. Exactly.
That's not.
Uh-huh.
Yeah.
Yeah. Yep. That they had paid surgeons consulting fees and royalties that were essentially designed to secure exclusive use of their implants. These were not payments for genuine consultation, they were payments for market share. And these device reps, like we were talking about, that are in the room and they create this dynamic that goes beyond financial payments. The relationship itself, the trust that they get in with the doctor, they know the preferences. They get to know
They
what
get
a
to know
doctor
what a doctor
likes.
likes.
So then they'll have your supplies ready for you before you even ask. So does that kind of create that form of the dependency on the doctor? Like you're saying, he's in there and he's supposed to be doing the procedure, but he has someone saying, well, no, this would, probably
Yeah.
be better.
Well, and
And
it's
why
like
would they question that in some ways?
Right. Well, and if you're catering to my likes and dislikes, then I'm going to trust you even more. So then why would I question your expertise on the device?
Well, and it's exactly like Dena said, like the physician becomes dependent now on that individual. And so I'm going to keep using their product because I don't
I'm
feel
going to have him
comfortable
come in here and
doing,
say, this is best for this. And then those are hard to quantify,
So here's a question that I have on that. Do those medical device reps have any medical background?
Well, they don't have the same background that the physician does, for sure.
No, not anywhere close. They have to learn
Yeah.
it, but they have the best knowledge of the device.
But they don't have the medical background
Not like
as
a
the
doctor,
holistic
not
approach
like
of the
a
doctor.
No,
cardiologist or an
Right.
interventionalist, no.
no. Yeah, it's like Dina said, they have the expertise of the device and how the device is supposed to be used.
Yeah.
So yeah, yeah. So we have a federal law from 1972 that prohibits this. We have the Stark Law on top of it. We have the False Claims Act as an enforcement mechanism, and we have the Open Payment Database making payments visible. And we have billions of dollars in annual settlements. So why does the machine keep running? We're going to go there.
Let's go there.
All right. The Anti-Kickback Statute has what are called safe harbors, regulatory exceptions that define categories of financial arrangements that will not be prosecuted even if they technically involve payments related to referrals.
And this is why those attorneys exist that we talked about,
Uh-huh.
right? Is that they
Yes.
can say, you really can't do this, but there's a safe
10 years.
harbor.
Here's a way
Yep.
to get around that.
Yep, and the safe harbors are for personal services arrangements, for fair market value compensation, for investment interests in ambulatory surgical centers, for electronic health record donations, and many more. These safe harbors exist for legitimate reasons. Not every financial relationship between a physician and a company is corrupt, and the law needs to accommodate legitimate business. The problem is that they function as a compliance checklist that sophisticated actors use to structure arrangements that satisfy the technical requirements of the exceptions while serving the same corrupt purpose the law
Sorry,
was
guys,
designed
my
to
dog
prevent.
is drinking really loud.
Drinking or eating? Which
It's his collar that's hitting the water
the
bowl.
water. And who knows what they're picking up, but you know.
That's all right.
So let me give you an example of all this. The Personal Services Safe Harbor requires that a compensation arrangement be set out in writing, cover all services to be provided, specify the compensation in advance, not exceed fair market value, and not to be determined in a manner that takes into account the volume or value of referrals. A company that structures a consulting agreement to meet all 5 of those technical criteria has a safe harbor defense, even if everyone in the room understands that the real purpose of the agreement is to reward. The agreement is to reward. And
Yeah.
you think about this, you're talking about paying lawyers and
Right.
paying people to come and read to the same group. I mean, how much are we throwing into this? But
That's why I was thinking the thousands and millions of dollars
Yeah.
that goes to this.
but then there's still a reward for someone.
And
Yeah, for someone.
As long as we meet those 5 criteria, which some of those are not very hard to actually meet,
Yeah.
Right.
then it's safe.
Well, I mean, like the law protects this form of arrangement. Like the law is designed to actually protect the arrangement, and it's so difficult to actually, prove intent. So if the law is designed to protect the agreement or the arrangement, and then it's also hard to prove that the intent was malicious, you're going to get away with it.
Yeah, get away.
You are. Yes, the intent is very hard to prove, which is why most of the cases resolve through Civil False Claims Act settlements rather than the criminal prosecution. So that's kind of what you were asking earlier.
Yeah.
We were talking, do a lot of the higher ups really,
Are they held responsible at all?
it's mostly just settlements.
Mhm.
The government doesn't have to prove criminal intent under the False Claim Act, and it has to prove that the false claims were submitted for reimbursement, but the underlying conduct that generated those false claims, the financial relationships, the corrupt referrals, often continues after the settlement because structuring the arrangement differently is easier than stopping it altogether.
Yeah. Crazy. Let's spend some time on the Stark Law specifically, because I think it's even more important to this episode than the Anti-Kickback Statute in some ways. And it connects directly to something we saw happen firsthand impact a practice that we were part of. So this is where it's really going to get personal for Dena and I. The Stark Law was passed in 1989 and significantly expanded in 1993. It was designed to do one specific thing: stop physicians from referring patients to facilities or services in which they had a financial interest. The drafters understood that a physician who owns a piece of an imaging center, for example,
Okay.
Mhm.
has a financial incentive to send patients for imaging to that imaging center. Okay.
Well, yeah.
Yeah. And that incentive corrupts the referral decision making process, regardless of whether it was explicit or not, right? You don't need a contract, you don't need a handshake. The financial interest itself is the problem.
Yeah.
Okay. And
Well, and I think that when we first introduced the Stark Law, you said it was also for family.
yeah, so it could
may
be
not
a
might
brother
be
who owns that, or a
right.
husband, or a spouse, or it could be a partner or whatever,
Right.
right?
Yeah.
Okay, so the Stark Law has extensive exceptions, though. So, in an office and ancillary service exception is the most significant and the most abused. It allows physicians to refer patients to services provided within their own practice, imaging, laboratory, physical therapy, without triggering a stark concern. So, does that make sense with what?
Yes.
Okay.
Yeah.
Okay. The rationale is that an in office service can be more convenient for the patient and more efficient in care delivery. So, this could be where you have your patient comes to your clinic, you now want them to go and have an x ray. And the imaging is done down the hall, and it's something that you're also part owner of that
Right.
part. But because it's in your facility, they're going to it's excused because
Proximity makes
the
a difference.
proximity, exactly, for patient care and efficient care for patients. The reality is that the exception has been used to build physician-owned profit centers that generate enormous revenue from self-referrals. MedPAC, the Medicare Payment Advisory Commission, has documented repeatedly that physician-owned imaging facilities, for example, perform significantly more imaging per patient than non-physician-owned facilities. Does that make sense to you now?
Yeah.
They're ordering more imaging than if you didn't own an imaging center.
Because it's bringing in more
It's
money.
bringing money. The financial interest produces more utilization consistently, right?
Right.
And then there is this whole hospital exemption and the ambulatory surgical center investment exception, both of which have created an entirely separate category of problem: the physician-owned facilities. Which brings me to something I want to specifically address in this episode because it is happening right now all over the country and most patients have no idea. I'm going to hit record.
Peripheral artery disease.
Okay. Oh, those are things like DVT and okay.
Yeah, and I think
There's
she'll
their
say it
diagnosis,
here,
yeah.
and then we'll just remind him. Yep.
Okay, what did we get to?
That's what I was
Failure
wondering.
3.
Okay. Okay.
The one that you guys are talking about.
Yeah, okay. One of the fastest growing areas of healthcare delivery right now is the office-based lab, or OBL. These are physician-owned facilities that perform interventional procedures outside of a hospital setting. Cardiology, vascular surgery, and interventional radiology procedures that used to require a hospital or an ambulatory surgical center now can be done in the office. Okay? And it can be done in a freestanding environment. So, there are genuine advantages to this model. There's lower costs, more convenient access, and faster scheduling for patients. But the OBL model has also created a self-referral problem that is extraordinarily difficult to regulate under the existing Stark Law framework. Here's the pattern. A group of physicians, often specialists like interventional cardiologists or vascular surgeons or interventional radiologists, open an office-based lab. They then invite referring physicians in the community, primary care doctors, podiatrists, other specialties, to invest in the facility. The referring physician becomes partial owners. And then, predictably, their referral pattern shifts toward the facility they own a piece of.
They really don't even the main owners of that OBL don't even have to say anything. It just happens. The referrals just start happening.
Yeah,
Showing
they just
up.
start happening. They just start showing up. Exactly. Dena and I saw this happen firsthand. The scenario involved podiatrists in this situation in the community that we're in, who had been reliably referral sources to for a vascular procedure to our interventional group. specifically patients with peripheral arterial disease, or PAD, and deep vein thrombosis, or DVT. These are serious conditions. PAD is in particular can lead to a limb loss if it's not treated promptly, okay? The referring podiatrist had been sending these patients to an established interventional group with strong reputation and proven clinical outcomes. And then a new office based lab opened in the area. And within a period of months, the referral patterns from those podiatrists shifted dramatically and almost entirely away from the group and towards the new OBL. When you looked at why, the answer was straightforward. The podiatrists who had stopped referring were investors in the new facility. They had a financial stake in its success. Every patient they sent there generated a return on their investment. I am being very specific about not naming names or anything like this. So we're just being very generic in the specialty and the OBL. Okay. This is the Stark Law problem in its most current and most difficult to regulate form. The Stark Law's whole hospital exemption and its ACS investment exemption created a pathway for exactly this type of arrangement.
So I have a question. And I don't know if you know, like in that referral process, when they were referring to their own entity, were they charging less or doing anything like that so that it was, because I could see them saying, well, we're not the patient gets to choose whether they actually go there or not. We're not doing anything wrong by referring there.
They were charging less than what a patient would experience in the hospital because that is the benefit.
But
of
it
an
would be the
office-based
same at
lab.
any
Exactly, but it'd be the same as any office-based lab. And I guess I wasn't very clear when I was describing our situation that we have witnessed and were kind of, I guess, victim to, I guess, in the situation. But we were already an established office-based lab. We were already offering lower cost care to patients, but we were a group that did not have outside investors. So we weren't having referring patterns that were being, in a way financially gained to the referring provider. The referrals were coming through because it was the reputation that the doctors had already built with the referring providers and the care that they were already giving to the patients.
Right.
So, if the investment's structured correctly, if the ownership interest is proportional, if the facility meets certain size and Medicare billing requirements, it can entirely be legal under existing law, even though the underlying dynamic is precisely what the Stark Law was designed to prevent: a financial interest corrupting a referral decision.
Yeah, so all of these patients in this scenario you just described, the PAD patients, the DVT patients, they started to be referred to a new OBL. And they may not be referred to maybe somewhere that would be able to offer
The
better
best care.
be better equipped to treat them. They're just going to the new facility that is most financially beneficial to the referring physician.
Yeah, that's right. And bandits, again, very upset about
that. Dang it.
Yeah, that's exactly right. And this is where the patient harm becomes concrete and direct. PAD and DVT, I don't know if I said what DVT was, it's deep vein thrombosis, are conditions where the quality of the interventional team matters enormously. An established group with high procedure volumes and proven outcomes is not equivalent to a newly opened facility staffed by less experienced operators. Procedure volume correlates with outcomes in vascular intervention. It is well documented in the literature. When financial interests drive referrals away from quality and towards ownership stakes, patients pay the price in clinical outcomes. And here's the other thing that honestly is one of the things that kind of bugs me too, is that physicians are not required to disclose that they have a financial interest in a facility that they're referring a patient to.
So, and they only have to refer to one place. They don't have to give it multiple options.
No.
They don't have to. I mean, it's better to give patients more options, but they are not required to.
And a lot of patients won't ask. This
Right,
is who
just
you're
trust your
referring to me. Yeah.
Yeah, exactly. There's no federal requirement that a physician tells a patient, I own part of the place I'm sending you to.
Right. Yeah.
So some states have enacted disclosure requirements, most have not. And even where disclosure is required, the practical power imbalance between a physician and a patient, we kind of talked about this when we did the oncology one, where who are you to question where they're recommending for you to go? And so it means the disclosure alone does not neutralize the conflict.
The Physicians Payment Sunshine Act.
Scatter sunshine.
Kind of an interesting name, right? I haven't even talked about it, but Sunshine Act passed as part of
not the song that came to my head. Mine
what
was
was
like,
yours?
mine was "You Are My Sunshine, My Only Sun." But Holly's like, that was great.
Well, this act was passed as a part of the Affordable Care Act in 2010, created the Open Payments Database, which requires pharmaceutical and medical device companies to report all payments made to physicians and teaching hospitals. The database is public.
Okay.
Yeah, there you go. You can go to cms.gov and look up how much money their doctor received from the pharmaceutical or the device company in any given year. So this is really transparency, right?
It is
an achievement.
I'm feeling like there's going to be a backside to this.
There's always a but. Have you not been listening and paying attention to all of our episodes? There's
oh wow.
Are we?
We went there.
Wow. She went from scatter sunshine to big butts.
Well,
I like the big butt.
You can.
Oh my goodness. Okay.
Okay. So the Open Payments Database has produced extraordinary journalism. ProPublica's Dollars for Doctors projects has done years of invaluable reporting on what those payments look like in aggregate. We know because of that database that in 2022 alone, pharmaceutical and device companies reported paying physicians and teaching hospitals more than $12 billion in transfers of
a billion
value. $12 billion in 1 year. That's meals, speaking fees, consulting arrangements, research payments, and travel.
That is insane.
I would just take like a quarter.
Would you even take a quarter of that?
I wouldn't even need a quarter
So
of that, but a quarter of I'd be set for life.
Well, you would be, but instead you're just paying for instead to help. So there's big money there, right?
Yeah,
We've known that. Big pharma,
money.
right?
Yeah, big pharma.
The database's existence has not meaningfully reduced those payments. It has made them visible. So making them visible hasn't
really dissuaded anything.
Nope. So visibility and accountability are not the same thing. A physician can receive $50,000 a year in speaking fees from a pharmaceutical company. Have that payment fully disclosed in the Open Payments Database and face zero regulatory consequences because receiving the payment is not itself illegal. The illegality, if it exists, is in the link between the payment and the prescribing behavior. And providing that link is enormously difficult. So is that why it's called the sunshine? Because sunshine for someone.
Yeah, it's not.
You can look it up.
I think you might have nailed it as to why it's called the sunshine. I mean, seriously though.
This is a repeat pattern though that we've talked about over and over again in our podcast. Is that just because it's transparent doesn't mean it changes anybody's behavior.
Doesn't, right. Well, and I mean, if you think about it, and like how Dena said that it's hard to prove that they're prescribing something because of that
there's a lot
payment.
There's a lot of
they could easily
they could
easily say, I prescribe it because I feel like it's the best thing for my patients, and I have all of these results of my patients being on this medication, and look how they've improved, and that's why I'm doing it, right?
Because I haven't prescribed any other medication to know that there's something else better, but my evidence shows
that this is the right
working.
thing. Exactly. So
it's improving situations better than they were.
Right.
Maybe that's great and not great.
Maybe there is something else better, but they don't know that. And so it's giving them a good enough result to do what they're doing. And that's the thing is like you already said something right there is that you're like in a lot of our podcast episodes, we have talked about transparency doesn't prevent. And it's because there's not the enforcement part of it. That's the issue is that we're not getting enforcement on a lot of these things.
My thought too is, do we even as a country have the capability to enforce what is happening
No,
in big pharma?
probably
It's
not.
too expensive.
It's too
No.
expensive, and there's just too many to be able
Yeah.
to stay on top of. I know you named 5,
Right.
but that was only 5. Those
And
were
then
not
they
even-
divided, we said a lot of money that they needed to pay out, but to them,
It's small. pocket
once you
change.
divided that, yeah.
Exactly. Well, and I think that we kind of go into that a little bit. I can't remember if we do touch on the fact that some of these fines are like a drop in the bucket to the pharmaceutical companies. So it's
We talked
worth
about
it to
that
them.
before.
Yeah,
So,
exactly.
The risk of getting caught is so small
Yes.
compared to
Yeah.
output.
Well-
the outcome if they don't get caught, that it's worth. And even if they do get caught, their outcome is so
It's still
great that
it's so
that
much
is-
better still. Exactly.
Slap on the wrist to
Yeah,
them.
exactly. So let's talk about the enforcement part, right? So let's talk about, because Holly did ask if we could get actual enforcement in our country, right? So the DOJ False Claims Act settlement sounds impressive. Billions of dollars recovered until you compare them to the scale of the conduct. Okay, so this is where I was like, I think that we do go into this. So we are going to go into it right here. The DOJ, the HHS, and the OIG, so we kind of talked about what those are the primary federal enforcement bodies for healthcare fraud. They do important work. The False Claim Act, which is like the whistleblower provision, has been one of the most effective fraud recovery tools the government has. But the enforcement model is reactive. It responds to complaints, to whistleblowers, to investigative referrals.
The squeaky wheel.
The squeaky wheel, exactly. It does not proactively monitor the payment relationship between the pharmaceutical industry and the physicians and generate enforcement actions based on what it finds in the open payments database. The data and the enforcement apparatus exists in separate silos. This is one of the most important and most damning structural realities in this entire space. The False Claim Act allows the government to recover 3 times the actual damages. That sounds punishing, right? So, I mean, if you can collect 3 times, like, so say 50,000, but they can
Right.
actually collect 150,000,
50,000.
right? So it sounds punishing, but when a pharmaceutical company generates billions of dollars in
Yeah.
revenue from a drug that was marketed through an improper speaker program or a settlement, like the settlement of hundreds of millions of dollars can still represent a net profit to them.
Right. Yeah. Well, and then the thing is, they are not. There's not a consequence for them for the word of mouth type.
Yeah.
Because a doctor who might have received the kickback then is talking to their colleagues about this.
Yeah, it's true.
And so then it's spreading, and now the pharmaceutical company or the device company is getting the profits from that.
Right,
but
but
it's not illegal
and they
at that
maybe
point.
only had to
Right.
pay the fine of the one physician,
Right.
but not the
All
word of
the
mouth part.
others.
Yeah, exactly.
Mhm.
Yeah. So Novartis paid $678 million in 2020 to settle kickback allegations related to its speaker programs. Its revenue in that same year was approximately $48 billion. Okay, so they paid $678 million, but they made $48 billion.
So they didn't even cut down. one of the
Exactly. The
billions.
settlement was less than
Yeah,
one.
no, they didn't even hit
Right?
1
Exactly.
billion.
The settlement was less than 1.5% of their annual revenue.
See, and that just seems crazy to me that ouch, but it isn't that big of an ouch.
Well,
Yeah.
it makes me think about when we say 1% of somebody who's making $10, that is an ouch.
Right.
But when you get
That's
to
true.
the big 7-digit zeros,
Yeah.
1% is not an ouch.
No,
an ouch.
not at all.
So no individual went to prison. The company paid. The conduct in various forms across various products has continued. So it's not a deterrent. This is the pattern across the industry. Corporate settlements without individual criminal accountability produce settlements, not behavior change.
Right. Let's spend a moment on something that I think is as important as any of these legal failures we've talked about, and that is the culture normalization of these relationships inside medicine, because the law can only do so much if the profession itself doesn't see the problem. Medical culture has historically treated the pharmaceutical and device industry relationship as a feature of professional life, not a threat to clinical integrity. Drug samples in the office, lunches provided by the sales rep, conference sponsorships, speaking opportunities. These things have been a part of the fabric of medical practice for so long that many physicians and those trained, long before in the decades before, um, I personally think they're just kind of used to it.
Well,
So I was
and they don't think that it's influencing their decision.
well,
Right.
and I was going to ask because you guys both worked in a medical office, and as an outsider, I have heard not from you guys, but just that a lot of medical offices love it when the reps come in because they bring the box of donuts or they bring
A lot of times
lunch.
they were bringing in
Right.
nice lunch. Like, I mean,
Right.
So did your office kind of like it when there was a rep coming because
We
we know we're
we
going to get this type
we
of
loved
treatment?
it. We just never
we
really
never really
received it as
allowed it.
much. I think there's
Yeah.
something we didn't allow it as much.
Our doctors didn't allow, because I mean, really, the whole thing is to get the rep wants to meet with the doctor, right? And so the whole point of bringing in a meal is to
Sit
kind
down with
of,
the doctor.
yeah, reward that opportunity for them to sit with the doctor. And our doctors kind of didn't, they tried to avoid having those type of conversations. Also, because our doctors also, even though they practiced in their own office for some of these procedures, they also practiced in the hospital. They did a lot of things in the hospital. And so there's a lot, I mean, there's a whole other side of like hospital regulations when you're
Yeah.
dealing with these reps coming in, right? And so I think that our doctors just kind of got used to, you know, knowing that there's certain things you follow when you're going to meet with a rep, and so they just really didn't open the door in our clinic. But I will
Now
tell
we
you, when they
cannot say
did,
it did not
it did
happen.
happen,
I mean, it
and we loved
happened.
it
There
when they
would be
brought in
times,
meals.
and it would, at times be ones that we had bought from prior, and then they're wanting to come in and
Right.
and remind you of their name
Their
and
product and their name.
yeah, their
and
name
what
and
they can
their
do for
product.
you.
So yes, but definitely as far as drug samples and things, I know
We
there was
never
a
got
few
drug
times
samples,
that we
really.
wished we had,
Yeah.
because there are patients who could use them for a
Right.
time.
We would have loved
that
drug samples for DVT
well, yes, because for
because those
clots,
medications are so expensive.
they're so expensive, and so it'd be nice just to give them to them because there's only so many you can prescribe anyway that are, that the insurance will take care of or that are really good. But
Yeah.
That's okay. I just was wondering about that.
right,
No, yeah. So I mean, but to answer your question, did the staff love it when it would happen?
yes,
Absolutely.
Yeah.
yes.
And they're banking on that.
Yeah.
Oh,
They
yes,
really
they are, and that you'll talk it up and remember them or get you behind,
Yeah.
to the doctor.
Or they brought the best.
Yeah.
Like if we were comparing this company with that company, they brought in the best thing, and so we'll
Oh, yeah,
remember
we'll
that.
remember them.
Right.
Yeah.
Well, and I think that the samples for sure, I think that definitely sways, right? Because if you are dealing with a pharmaceutical company that maybe doesn't bring as many samples as another company,
Mhm.
your providers are going to lean towards prescribing the one they have more samples
Sample stuff.
of.
Well, because they can first give it to the patient to try,
Right,
and
Yep.
then
Yep.
right,
have more to give to other patients.
Exactly.
right. So this gap is a cultural problem. It's not necessarily a legal one that these physicians are in, but medical schools are trying to improve on this and address it. Many now have policies restricting industry access to students and residents, and some have added conflict of interest education to their curricula. So it's kind of good because
Yeah.
I'm sure there's many students who go into it who think this is just normal.
Right.
They've probably worked in an office
Right.
at some point. But the physicians who are currently in high prescribing, high referring positions were largely trained in an era when none of this existed. They built their professional identities and their practice patterns during a time when industry relationships were considered entirely normal. Changing that is generational work.
Yeah. So it's going to take time. It's going to take time to change. So let's talk about what actually has changed. Let's talk about where we are at, what's changed, what's better, and what still needs to happen. Let's start with progress, because there is some. The open payments database is real transparency, the database that Dena talked about, the infrastructure that did not exist before 2013. The OIG's 2020 special fraud alert on speaker programs was significant. It put the industry on notice that speaker programs with the characteristics we described earlier would be scrutinized regardless of how they were structured. Many large pharmaceutical companies have voluntarily reduced or eliminated their traditional speaker programs in response to this guidance and to the wave of the False Claim Act settlement. The incise is we said
Incise.
incise prosecution was also meaningful because individual executives actually went to prison. The DOJ has stated explicitly in what's called the Yates Memo and in subsequent guidance that individual accountability in corrupt fraud cases is a priority. The theory is that the companies respond to financial penalties, but individuals respond to the prospect of personal criminal liability. Whether the enforcement apparatus has the resources and the political will to pursue individual accountability consistently is a separate question. In this case, like in the incise case, involved conduct so extreme and so well documented that prosecution was relatively straightforward. The more typical case, a consulting agreement that nudges prescribing behavior in a measurable but legally ambiguous way, is much harder to prosecute. The CMS issued a significant, so CMS is the Medicare, issued a significant Stark Law update in 2020 that made a number of changes, primarily streamlining certain exemptions and adding new ones related to the value-based care agreements. The intent was to reduce regulatory burden on legitimate care coordination arrangements. The criticism from patient advocates and healthcare fraud attorneys was that the rule loosened restrictions in ways that could create new opportunities for the kind of self-referring arrangements we've been discussing. It also added a new exemption of cybersecurity technology donations and clarified the definition of fair market value in ways that, depending on who you ask, either reduced manipulation or enabled it. Regulatory reform in this space is honestly complicated because the same financial structures that enable fraud is enabled legitimate and beneficial arrangements. The goal is not to eliminate all financial relationships between physicians and industry. Some of those relationships produce important research and clinical innovation. Like you kind of talked about, you want to know that this has been tested and that somebody is proven that what's being recommended for you,
finding benefit in it.
Yeah. The goal is to distinguish between relationships that serve patients and relationships that exploit them. And that line is very hard to draw in regulations without unintended consequences on either side.
So what does meaningful reform actually look like? If you're talking to Congress, to CMS, to the OIG, what do you tell them? Well, several things. First, close the in-office ancillary services exception to the Stark Law or dramatically narrow it. MedPAC has recommended this repeatedly. The exception has been used far beyond its original intent and has produced documented overutilization that costs Medicare billions of dollars annually. And we don't need Medicare paying more.
No, we don't.
We need it here for us.
Exactly. We need Medicare to be around for when we need it.
Second, require mandatory patient disclosure of physician financial interests in referring destinations. Not optional, not state by state, federal, standardized, and in plain language at the point of referral.
And when you say that, because I thought you were saying patient disclosure, but it's really disclosure to the patient.
Right, discllosure to them. Give them more, or more than one option. Yeah, like you have a stake in this one, but yeah. Right. Third, increase funding for proactive enforcement. The open payments database should be actively analyzed for patterns that indicate improper relationships, not just used as a reference library for whistleblower cases. Fourth, implement meaningful individual accountability in False Claims Act settlements. Corporate guilty pleas without individual prosecution do not change behavior. Fifth, address the self-referral gap directly through rulemaking that closes the ownership referral loop for physician-owned facilities.
You know, when you said that one about, I think it was the fourth one where you made the comment that corporate pleas don't change behavior. There's something to be said about the court of public opinion. And when those are done behind the scenes, nobody knows that they're happening. And so if they were to be charged and taken to court in a public manner, that may change the public opinion of what is happening as well.
Shed some light on some things, right?
Yeah.
True. Add that to the sunshine.
Yeah, to the sunshine. To the
scattering.
Scatter it. I mean, and let's talk about the fact that the open payments database is attempting to do what you're talking about. right? Like, I mean, a lot of people don't know about the open payments database,
Right.
but it is attempting it in a way where it's trying to bring that information to light that, oh, my physician might be getting paid for prescribing this. And I actually honestly do recommend it might be interesting. I wanted to go on and I haven't taken the time to do it, but it's open payments data.cms.gov. So that's the website. But you can go on and look up your physician and see if they've been given any.
You're going now, aren't you,
I was
Holly?
gonna say Holly's going
Holly's
on
like,
right
I'm
now.
checking it out.
Checking it out.
You can look up your physician by name and see every payment they've received from a pharmaceutical or a device company in a given year. So which is awesome. And you can find out what it was for, how much it was, and who paid it. So you get specifics as to what company, they were paid from. It takes about 60 seconds. So Holly, tell us how long it's going to take for you to, I mean, you obviously don't have to tell us if they took anything.
Well, no, but just how long it takes
How
you to get
long
in
does it
there and
take you
find
to get in
it.
there and find it?
To get to the website, obviously was real quick, but I'm not able to read the website and listen to you guys. At the
Oh
same
yeah, that's
time,
true.
So
Okay, so I won't ask you. I won't ask you questions right now. You just do
Right.
your whatever your research is. Okay. We will link to it also in the show notes. It will not tell you whether your doctor's prescribing decisions are influenced, so you can't determine that, but you can tell if there's a relationship that exists. And you have every right to ask your doctor about it. I want to end on this. The vast majority of physicians are not corrupt. They are not taking payments in exchange for referrals. I think that we try to emphasize this in every episode that the things that we're talking about are not the norm.
Which is true because I've had the questions before. So you prescribe this, you guys get a kickback for this,
Right.
prescription for clot,
for Keflex,
for DBT,
or
and it's like
for
we
Xarelto,
absolutely
or,
do not.
Not Keflex, that was
So
be the antibiotic.
I'm
but
sure there's
Xarelto.
many who don't.
Okay, so I typed in one of my providers, and I'm not going to tell you who,
Okay.
but they had a general payment
You did find one.
for the 20, and it's the year 25.
Okay.
$21.43.
What did they do?
Whoa. I want to know
my
what that was.
gosh.
I think I'm going to take it to
I
them
know.
and ask.
You're gonna.
What
What
is
was
this?
this?
And
Has this influenced your decision?
And I almost wonder if they had any idea.
No.
Somebody probably brought in a donut.
Or something. My goodness. Okay, well, that should make you feel better that it's like, yeah, totally.
But what I thought was interesting about this website is it's looking it up by year.
Yeah, it does.
And-
That's why I said you can break it down by year.
So, but then it says this physician that I looked at has data available for 2019, 20, 21, 22, and 25.
So they didn't do anything in
those other
2023
years.
and 2024.
Right. Yeah. So I just think that's interesting.
Okay. And it could be that they were on a break. Like, I mean, depending on what the reasons that the physician could have not been practicing for a couple of years and decided to become,
Right.
So
I went back to one of their previous years.
Ooh.
Big dollar amount here.
Oh
You ready?
no.
2167.
Oh, they just are right
Yeah,
in
they're
there, aren't
they're
they?
just
20.
hovering over at that 21 mark.
They are.
Most of the financial relationships in this space exist in a gray zone where influence is real, but intent is actually unclear. And the physicians involved.
This time Cassidy's
I'm
upset.
so sorry, guys. That was Cassidy now. She's just outraged by this too. And the physicians involved may sincerely believe their decisions are clinically driven. The problem is structural. It is the architecture of financial incentives that medicine is built inside of. Fixing that requires changing the architecture. It requires policy. It requires enforcement. It requires the profession itself to hold a harder line. Individual physician integrity is necessary but not sufficient. The machine does not run on bad people. It runs on a bad system. So, more than $2.5 billion recovered in False Claim Act settlements in a single year. $12 billion in reported payments from pharmaceutical and device companies to physicians in a single year. A federal law on the books since 1972 that has not stopped the conduct it has been designed to prevent. That is the state of the kickback machine in American healthcare. Not a secret, not a conspiracy theory. It's documented. It's reported, it's settled, and then repeated. The patients in the particular story are all of us. Everyone who has ever been prescribed a medication, referred to a specialist, sent for a scan, or recommended for a procedure. We have no way of knowing in most cases whether that recommendation was clinically driven or financially incentivized. That is not acceptable. And the fact that we have largely normalized it, that this is just how medicine works, is perhaps the most damaging thing of all. Dena, do you have any final thoughts?
I do. I do have some thoughts on this because the transparency that we have is necessary, but we're seeing that it's not sufficient. We have the data out there. We can see the payments. Holly just looked those up. But what we have is the lack of the institutional will. We need it in government, in medicine, and the industry itself. We need to treat this what's like best for the patient and for their safety, as to where they really should go. The
Yeah.
referral should not be driven by a monetary.
Yeah.
It needs to be clinical judgment, that sends them to the appropriate places,
Yeah. I agree.
so they don't get the wrong care. And that's not a billing problem. That is a harm problem.
Yeah, I agree.
We need to treat it like
You
that.
treat it like that. I agree. Holly, thank you as always for your questions throughout. I mean, in the script, I have Holly's response. So are you sure? Do you want to act on that or anything?
Well, yeah, because I'm now sitting here just going down a rabbit hole.
You are going, you're looking at other providers and other years. And
I know. She's spaced out now. I was going to say, put mine in.
But what I think is interesting too is it not only tells you about your provider, but you can also see the mean and the median of
their specialty.
Oh.
And thankfully, as I'm looking at my providers, as I've looked them up, they've all been well under the mean and the median. So I'm like, okay, so my providers are at least up front with that. Or,
I'm really curious about, I want to look up one of my providers.
Well,
for sure.
We will.
And I think the thing is that when you're on a prescription or have had a medical treatment that may have fallen into this category, you want to look it up and go, oh, okay, what kickback did my doctor get from this?
Yeah, and they might not have gotten a kickback.
Yeah.
But I mean, as you know, I was on a medication that was working very well for me. It was helping me. It was making me feel better. The listeners probably listening don't know I have rheumatoid arthritis. And so I was prescribed a medication that was working really well. And then all of a sudden I had to change my prescription because not only was it no longer covered by my insurance, but my insurance also recommended for me to take a medication that was even more expensive than what the previous medication was, which was just also really weird. So I am very interested to look into something like that to find out.
And as you dig into
and my physician might not have been influenced at all. So
as you dig into this a little bit more, as you dig into the website, it tells you what they did receive. So
yeah, that's one of the things that I had mentioned is that it will tell you
food and beverage,
what it was. Yeah.
And then it also tells you what company
paid it.
Oh, really?
Yeah.
So isn't that funny that we talk about it, but we have had this.
We haven't
even looked. So if anybody takes anything from this today, if you've made it this far with all our blunders and the dogs, is that you can go to that website.
Yes, you want to. I was going to say, tell it again.
It's Open Payments with an S, Payments Data, all one word, openpaymentsdata.cms.gov.
And we will reference it in the notes.
Right. And if you're being referred somewhere, check it out.
Yeah.
See, I mean, that, if you've learned one thing.
Exactly. I agree, Dena. If you took anything away from this crazy episode, we are so sorry. We've been all over. I feel like today is more of a squirrel situation
it has been
than the other episodes.
Well,
but
it's a dog
it could be a dog.
It's surrounded by both of them.
Yeah, we're having a dog problem today. They're extremely needy today. But I agree. If you took anything away from this episode, go and check out that website.
I agree.
That is the main thing. Everything we referenced today, as I said, will be in the show notes, including the direct link to what we just talked about, that database. If you want to go deeper on the billing and financial structures underneath all of this, head over to Behind the Business of Healthcare. It's our parent channel. It's where we have covered some of the mechanics of the healthcare billing and coding in detail. We will be back next week with the dark side of healthcare. But until then, stay curious, stay critical, and know what your doctor is being paid. We'll see you guys next time because there is always more. Bye-bye.
Bye.
Bye.
Thank you for listening to The Dark Side of Healthcare, presented by Behind the Business of Healthcare.